TopMedTalk.
Well, hello and welcome to TopMedTalk. We are here in Denver, Colorado on the final day for the Society for Obstetric Anesthesia and Perinatology, or SOAP. I'm Desiree Chappell, co-editor-in-chief and host today of TopMedTalk, and joining me is a former editor-in-chief, Monty Mythen. Hello, Monty.
Well, the former bit still hurts a little bit, Desiree, but it's good
It's like
to be back.
every time I say it, it's like a little knife in there.
But at least I think I stepped down. I wasn't fired.
No pink slip for you.
Okay, because I joined Edwards Life Sciences, industry partner with the original sponsors of TopMedTalk, and an ongoing sponsor. And although I'm still an emeritus professor at UCL, etc., we thought it was too much of a conflict of interest.
Yeah.
So I fell on my sword.
But luckily, they let you.
They said when it's deemed to be appropriate.
When it's appropriate to come back.
But that's the conflict of interest is clear.
Yeah. Well, Monty, we are so excited to be here at the SOAP meeting this weekend. This is our first obstetrical meeting that we've ever been able to attend.
And it's been invigorating on a number of different fronts.
Yeah.
One is that clinicians in anesthesia, there's no way to avoid OB.
Yeah,
so
we have found it.
We've all done.
We've all been there.
So we've all got those stories from those days and those weeks and the scary bits, etc. It's such an amazing community.
Yeah.
Very, very positive, engaged, happy community, because from the point of view of human interaction, there's nowhere to hide.
Yeah.
That's a recurring theme. And they're really, really very research active, quality improvement active. It's a meeting of less than 1,000 attendees and there's 500 abstracts.
Yes.
And they all get listened to as well. They all get aired. They all get a chance. So this is the way to do meetings.
Yeah, we've had so many wonderful conversations with attendees, presenters, those on the board of director and committee members for SOAP. So you need to find out more about this organization.
Yeah.
And you can listen to these previous conversations. We've signposted all the different things that we've talked about within the show notes to the SOAP website and the wonderful things that they are doing. So please do check that out.
It's a global organization.
It is, yes, international. They have lots of people from all over the world submitting abstracts and good stuff like that. So please check it out. And we want to give them a huge shout out and thanks for having us here this year. We'll talk a little bit about how we got here in the past, but we appreciate, supporting us to have the exhibit hall booth. So thank you to SOAP. And thank you to all of our sponsors, which we'll talk about in a bit as well. But before we do, I think it's really important we introduce our next guest, who is a dear friend and someone that has been part of the TopMedTalk family since very early on. It is Dr. Brendan Carvalho, who is with us today, former president of SOAP. Brendan, thank you so much for sitting back down with us.
It's an absolute pleasure. SOAP has a very special place for me. I've been part of it for 22 years, and you coming here is kind of special and, broadening the reach. And so I really appreciate TopMed being here. So
we were talking to Pervez yesterday just about how we got here. And I think, whenever we saw you guys at ASA last year and said, we'd love to be there. And I think we've talked a little bit about it over the years. So thank you so much for having us. This is really important information to share. And Monty and I were talking about, we've learned so much, just from it's a totally different perspective for us. So thank you.
Yeah, it's interesting because I trained in South Africa.
Yes.
And then I did my anesthesia training in the UK. And I attended a lot of different conferences before my first SOAP meeting. And they were kind of just serious and not as much fun. And it wasn't a community like this. And when I arrived the first SOAP meeting, it was just like everyone knew each other. Everyone was hugging each other.
The South Africa link. So I said earlier, I've just finished reading Bruce Bickard's book, Professor Bruce Bickard from UCT, Cape Town now, not there before, about safer surgery in Africa. Right at the beginning of that book, the clear thing that comes through is a lot of the development of modern healthcare in totality, a lot of it really stems from childbirth. In other words, trying to make childbirth safer. Because it was very, very unsafe everywhere a few hundred years ago. And then part of the journey is, has it or hasn't it got safer in different places over time?
Yes, and I think, we all came from childhood. So there's a unit. And I think in anesthesia community, it's always been overlooked as an important area.
Yeah.
And I've often visited incredibly beautiful hospitals, and they're showing me around, and then I say, can I see the OB suite? And then you come through a few passages and you arrive at a place that's not at the same level as the rest of the operating rooms.
Yeah.
So it's taken a while to kind of appreciate how important it is. And in a way, sadly, in the US, the increased mortality that we've witnessed has brought a lot of attention, funding, and other activities that I think have started to improve the way we provide care in the setting.
Yeah.
Very, very sobering statistics. I mean, the world stats are very sobering. The US stats are very, very sobering because you kind of think, surely not around here, if you're sitting in. And then there's the relatively simple solutions that it'll offer.
Correct. There's statistics that say 70 to 80% of childbirth mortality is preventable, and not preventable by doing crazy, elaborate, expensive things, simple things. I'm involved in the WHO, and that's incredibly sobering because obviously I have a good appreciation of guidelines in the US, but how we need to adapt it to the rest of the world, and just how basic things that we wouldn't even think about at Stanford doing just are not available or not done in other parts of the world.
Yeah. It's so interesting, I mean, we say that, and we've been talking a lot on the podcast, and of course, all of us, you can't run away from it, but hearing the statistics for maternal mortality and here within the U.S. And other countries as well, I think from, bringing this back to anesthesia, it's hard for some anesthesia clinicians and professionals to understand how we really fit into that. Tell us a little bit more about your feeling around that and how SOAP is involved in that piece.
Yeah, so anesthesiologists have been talking a long time about being perioperative physicians.
Yeah.
And it's been a difficult model to fill in operating rooms because a lot of our pay and training is related to the operating room. So moving outside of that has been difficult. In obstetrics, we've been perioperative physicians for a long time. Like at Stanford, we are involved in any high-risk case, any complicated case. We follow patients from when they arrive till they leave hospital. So it's a true perioperative physician aspect. If you look at the cause of mortality, we're probably the best qualified to manage a lot of these. So from hemorrhage to cardiovascular disease to blood pressure, control issues. So it makes sense for us to be part of the table. And I've definitely seen an evolution, at least in our society, where you would go to the best paper sessions or the research sessions, and it would be what dose spinal to put in and what dose of epidural. And it was very anesthesia specific. And I think once treatment modalities were reasonable, there's been a big shift now towards the real problems. And so you've got obstetric anesthesiologists that are essentially studying, doing more work than obstetricians. So you mentioned Pervez, but his entire work is...
I was just going to mention, say that. Yeah, is outside of this space.
Entirely outside.
Yeah.
Recovering from... So the first time we met, I think we touched on enhanced recovery. As enhanced recovery after surgery in the broader sense had become very, very fashionable around the world. It's been around for a long time, but it hit sort of fashion point about 5-6 years ago. And as part of that, almost everyone was discussing, should we try and do something like that in our space? What's happened in obstetrics?
Yes, it's interesting. Obstetrics was kind of late to the party to adopt enhanced recovery. But in a way, we had been doing it for a long time. Because we had standardized protocols for decades. We manage patients with a lot of the principles than you would with enhanced recovery principles. But I think we didn't frame it that way till a lot later. Some of it probably has to do with enhanced recovery often is focused on optimizing patients, and you generally have healthier patients.
Yes.
So, but we've realized that you can optimize other aspects like, hemoglobin, treating anemia earlier, which is probably the best predictor of the requirement for requiring blood after cesarean. So we were late to the party, but I think we've caught up for lost time, and, we've made a big inroads. And in fact, we're leading a big national protocol approach where a lot of people have worked in silos to develop enhanced recovery, and we've brought everyone around the table to come up with sort of a definitive enhanced recovery protocol.
And what have been the big ticket items?
That's what I was just going to ask too.
There are some enhanced recovery protocols that manage to get up to 40, 50 bullet points. Like they're so deep in the weeds, there's no hope. And there's, back to Henrik Kellett's original one, which had 4 major principles. I'm guessing there's a middle ground,
There's definitely a middle ground, and it's interesting because, what do you mean by enhanced recovery?
Yeah.
I was on a panel talk and someone asked the question, does Stanford offer enhanced recovery? And I had a colleague with me and we simultaneously answered. I said yes, and he said no. Just started laughing. So you're absolutely correct. Like, how many interventions do you have to do for it to qualify for that? And it actually hasn't been defined that there's a certain number. I think most of us would view it as more than 2 in at least the pre-intra post-operative phase. The evidence base behind specific interventions making a difference, specifically for enhanced recovery, is actually kind of weak. So generally it's just bundled together. If you bundle it together, the evidence that it makes a difference is fairly strong. But take something like spinal hypotension, running phenylephrine to prevent that. We have very good level 1 evidence that you can prevent it. But does that prevention then lead to better recovery? So the difficulty is trying to show all those inventions actually finally lead to a better product at the end. A woman's getting out of hospital with a better recovery afterwards.
And is there any sense, because in the adult major non-cardiac surgery world, the evidence is getting clearer that short-term recovery equals better long-term recovery. We're overlapping with the Pervez space. I mean, we always sort of get that sense that even if they don't want to go home, the mum that's walking around the following day and nursing their own baby and going to the bathroom, they're mobilizing, the drips are out, the vomit bowl's gone away, you kind of get the impression the next months and years are going to go better. Is that
correct?
Fair? Do you have any evidence to support that yet? Because it's taken a while in the adult world to get it. It's there now.
Yes. We have some evidence now. A lot of the work that Pervez has done. There's an Israeli study that we were involved in as well, that scores of recovery within the hospital predicts how well someone's doing at 6 weeks. So there is evidence. What we don't know is if we make an intervention or a change, does it actually then impact later on? But probably makes some intuitive sense that if we did something, early on for those who are not recovering well. And I think if you generally look at cesarean deliveries, the majority of women do very well. We conducted a study where we called women every day after their delivery until they reported no pain, no analgesic use, and recovered back to where they were before the surgery. And you see this recovery, and some women goes on for beyond 3 months, where they take a long time. But we then broke it up into the 80% of women and then the 20% that do. And the differential between those is huge. So there's a certain portion of women that don't do well that definitely need extra intervention. Saying that, the whole premise behind enhanced recovery is to provide standardized care to all at a base level. But I think along the way, there has to also be the ability to branch out to individualize some individuals who are not doing well with the standardized treatment.
I ask you, Desiree, and then, sorry to do that, I'm now interviewing.
No, that's yes.
Because you've done a lot of work and multi-facility work as a vice president of quality at a big healthcare system. What do you think the big ticket items are? And then we'll just cross-reference. What's really, from the long list of things, what's stuck and makes a difference, do you think?
Yeah, for me, so I, in our space, we have over 200 facilities, and trying to standardize everybody's certain protocol, you're never going to be able to do that.
This is not OB now, we're talking.
I know, yeah. So I did an ERAS for all, as that's our template, and you should be doing as much pre-op preparation and getting the patient ready as you can that is available. But the first one is making sure that you're going to, at least address MPO status and hydration before you come into surgery. Those are the big one. Pain control, multimodal pain control, whether that is using a block or if you don't do lots of regional at your place, you need to do multimodal. So you need to do something. So pain management.
But not too prescriptive.
No. I mean, you can't be. Yeah. I mean, you can't say you need to use dexamethasone infusion at this rate for these patients. I mean, you can't do that. And one thing I have found that I love about enhanced recovery is though it is standard. We have a lot of standards and we say, like this is we are going to be within this. It actually is individualized because you're giving what the patient needs to make sure that their pain is under control, but that we're not just flaming our patient. Anyway,
standard objectives.
Yeah, standard. That's probably a better way to say it.
So multimodal analgesia.
Post-op nausea and vomiting prevention is a big one for me. So that because we want to be good partners, and that is really important to manage for our patients. And then the patients living the dream, drinking, eating, and moving after surgery. Those are the biggest things, and as soon as possible. which we always say, our OB patients, they were the first ERASH patients because they're the ones that had to get up and move and drink and eat. So those are the big tenets for us, in hemodynamic management. So intraoperative goal-directed therapy and management of fluids and hemodynamics.
Which means different things to different people.
It does.
But if you do those things, it enables drinking, eating,
it does,
mobilizing, which in the UK has now been, there's an evidence base now.
Yeah, that's as if you do that. Yeah, if you do.
Is it very different?
It isn't. I mean, there's obviously a lot of commonality. My bias is that probably the most important part is post-op.
Yeah.
Unequivocally, and I think the problem we were mentioning, the perioperative position part, is most of us, as soon as a patient leaves the operating room. So I think if you want to make a difference truly to getting patients out of hospital sooner, you have to get involved in the other care providers, the obstetricians, the nurses, to make sure that the post-op aspects are being done. But for intra-op, for sure, and pre-op, for sure, it's education, preparing, getting patients ready, possibly optimizing if there's a need to optimize. Intraoperatively, it's the same. You've got to get the pain starting to go. You've got to avoid the side effects. Remember, for cesarean delivery, it's a very different model. Everyone's awake with spinal anesthesia. That has advantages because we can use neuraxial morphine, which is a very friendly enhanced recovery analgesic, and the fact that it has 24-hour half-life and no catheters, and off you go. But it also has side effects, so you need to balance those two. And then blood pressure management, like you mentioned, with lots of evidence suggesting phenylephrine infusions or other alpha agonists to prevent spinal hypertension. And then post-operatively, as you say, it's the dreams. And the things we still struggle with at Stanford is early catheter removal. It's way more easier for nurses to keep the catheter until the next morning because you're not having to help the woman pee.
Yeah.
And mobilizing is difficult, nursing workload, getting them up, etc. And what we've tried to do at Stanford is we have tick marks about where patients have to be, and it's forward-facing. They know where they should be. We have ones for the baby as well as the mom, because what makes this a very unique enhanced recovery is that you have two patients.
At least.
Two patients. And you can't get a woman out of the hospital unless her baby's generally doing well. And the biggest problem, especially for first-time moms, is breastfeeding.
Nursing, yeah.
So, you have to emphasize that. So, I'll say there's a lot of similarities, but the big differentiating one is that there's two people involved, and you have to get all things done concurrently, efficiently to get women out. And unlike the UK, we don't have very good, once the woman leaves the hospital, it's difficult. We don't have very good outreach. So we do have to spend a little longer getting a woman ready.
Yeah.
So people wonder why I talk about my OB experience. I'm just going to expand on that because back in the UK, you always had to do OB on your rotation. But also when I was doing my higher degree, my PhD equivalent, the only way to get the money was to volunteer for all the nighttime OB shifts. So that's what I spent.
I wondered about that.
As an intensivist, I spent a lot of time doing OB. So the reason for that prelim is one of the things that used to strike me back in the day is that once the baby's out, the mums are often really not fully resuscitated. That they'll do okay because they're young and fit and they'll get there. But I'd see them lying in bed, grey, still with a vomit bowl, and I'd start to intervene and say, look, we just haven't finished here. Has that changed? Because
it has changed a lot. And
Right.
I mean, the management of blood pressures, from 20 years ago is turned on its head. There used to be emphasis on loading, like fluid loading, and we now know it's an afterload problem. So there's a lot of emphasis on correcting that, and then you basically minimize it. So the days of a woman vomiting are much reduced. It's actually generally rare for a woman to be.
But in the 4 hours post-op, however long it takes, or the 2 hours post-op, when everyone's run off to look after the baby or whatever.
Yes, obviously, and that's another area where it's a little different to other enhanced recovery, where you try and fluid restrict.
Yeah.
For C-sections, you're going to lose on average, around a litre of blood loss. So you don't want to fluid restrict too much because then you run into the problem with hypertension in the post-operative care unit. We've put a lot of emphasis on accurate measurements of blood, like quantifying blood, so you don't underestimate how much blood loss generally. There's more point-of-care devices to get rapid assessments of hemoglobin, etc. So I mean, you still see it, but it's a lot better than it was a while ago.
Because we've seen in this, sorry to interrupt, but in the adult non-cardiac post-op world, from elsewhere around the world, that we're seeing enhanced care, just a little bit more attention to detail, making quite a big difference. So that window is possibly still there as an opportunity.
Yeah. And then Pitocin dosing used to be very aggressive.
Oh, yeah.
We've come down a lot with that, and that has side effects.
It's not a standardized guest dose, it's customized now, is it?
Yeah, and different places do different things, but generally there's an emphasis, if you're going to bolus, to use very small doses,
yes,
and then to run an infusion if you're using oxytocin. So there's definitely better, uterine atony management. It's not perfect yet.
Where can we do better? It's always hard to look at how we can do better from a world-class ivory tower. But where do you think where we can make the biggest differences to?
I mean, we're always trying to invent the next amazing product. I think just doing things we know well probably would make the biggest difference. And I mean that for not just enhanced recovery, but anything, hemorrhage being one of the leading causes. We know how to manage hemorrhage. So just do it well, have good protocols, have good training, good simulation. I don't think we have to reach for, the stars when it comes to fancy treatments or new treatments. It's been a little slow to get new developments going. There was a talk, Jesse Ansari was giving a talk on calcium, and there hasn't been a second-line uterotonic brought to the market since 1970, since the first Walkman, she gave an example.
The first Walkman.
So this is not a field that's advancing in leaps and bounds. And uterine atony is the leading cause of postpartum hemorrhage, 70 to 80% of cases. So there is a need to develop new drugs, but just listening to conversations in the WHO and watching the trial designs, it's just basics are not being done because of staffing, because of just lack of knowledge, lack of equipment.
I still haven't found out who said it originally, but the greatest innovation would be to do what we know.
Yeah, totally agree.
Yeah, absolutely. Well, on that note, Brendan, thank you so much. We really do appreciate it, and we wanted to give you a huge congratulations. You were a recipient of the Distinguished Service Award, which is SOAP's highest honor, and we can't think of anyone else that would deserve it. You're just amazing.
Thank you very much. It's a huge honor.
Yeah, congratulations.
There are so many talks that we've heard where they
Brendan. Brendan would know.
No, so the truth, you can't give a talk these days without saying COVID-19 or Brendan.
Or Brendan Carvalho.
So well done, Brendan.
Yeah.
And well done for not mentioning the Rugby World Cup.
Yeah. I know. It's okay. Breathe. It's all right. Or COVID for that matter. And thank you for listening to TopMedTalk. If you like what you heard today, you can always find us on TopMedTalk.com, your favorite podcatcher, your favorite social media platform. We're all over. Check us out. We're recently on YouTube. If you find us there, give us a thumbs up, subscribe to our channel. That always helps us out. Like I said before, thank you to SOAP so much. Brendan, thank you for having us here. And thank you to all of our wonderful sponsors, Edwards Life Sciences, GE Healthcare, Medtronic. You help us keep all of our content free and open access to the entire world. And we have listeners from all over the world. So wherever you are, thank you for listening. Thank you to our sponsors. And cheers, everyone. Have a great day.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EPPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is eppom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. eppom.org.